you all for joining us today for our webinar on policies and priorities in addressing tobacco use in residential care. It's particularly appropriate that we're having this webinar on June 30th because June is National Healthy Homes Month, and one of the best ways to maintain a home that's safe and healthy is to have a smoke-free environment. What we're going to be talking about today is tobacco use among folks who are especially vulnerable for a variety of reasons, including mental illness, physical, emotional, or developmental disabilities, or other cognitive impairments. We're focusing on residential settings for these individuals, many of whom live in supervised environments, such as assisted living residents, nursing homes, and long-term care facilities, where addressing tobacco addiction is seen as a low priority and where tobacco use may be common among staff and treatment providers as well as fellow residents. First, I just want to say that this webinar is sponsored by the Public Health Law Center located at Mitchell-Hamlin School of Law in St. Paul, Minnesota. We're a national nonprofit legal center devoted to advancing public health policy through the power of law. The Center's Tobacco Control Legal Consortium is our national network of legal centers and attorneys that support tobacco control policy change at the local, state, and national level by providing free legal technical assistance. Okay, our first presenter, Pat Mikone, is Regional Senior Director of Tobacco Control Programs and Policy at the American Lung Association of the Upper Midwest. Pat has worked for more than 30 years on advancing tobacco control policies and smoke-free initiatives at the state and local level throughout the Upper Midwest. Pat directs and coordinates the implementation of comprehensive tobacco control programs in 4 states, Minnesota, North Dakota, South Dakota, and Iowa, including cessation programming, adult and teen, grassroots advocacy, prevention education, and media advocacy. Pat's going to talk about the overall problem of tobacco addiction among vulnerable populations, particularly those with mental illness or cognitive impairments. Jessica Kulak is an adjunct lecturer at the State University of New York College at Brockport, where she teaches courses in psychopharmacology and global health. She holds a master's degree in school and community mental health counseling from the University of Rochester and a Master of Public Health degree from the University of Buffalo, and she's a PhD candidate in the Department of Community Health and Health Behavior at the University of Buffalo. Jessica has published peer-reviewed journal articles on tobacco policies in nursing homes, cessation patterns among African Americans, and research guidelines for monitoring the global tobacco use epidemic. Jessica will talk about policies to address resident smoking in nursing homes. And our last speaker, Jen Vitamin, is a policy and research associate at Finger Lakes Health Systems Agency. Jen has a master's in public administration from the college at Brockport and has worked in the field of public policy and government relations for over 10 years in academic, nonprofit, and government settings. In her current position, Jen advances policy systems and environmental changes with the Healthy Kids Coalition to support healthier, more active children in Monroe County, New York. Jen will talk about research of legislation governing tobacco use in Ontario, Canada, retirement homes. Okay, so before we start today's presentations, I want to remind you that we'll have a facilitated Q&A session at the end. Okay, so our first speaker is Pat Mikone. Pat?
Thank you, Carrie. It's a wonderful opportunity to be able to talk about this important issue. I want to set the stage for just what tobacco use looks like, especially for the people that we find in these vulnerable situations in residential care. So for most of the United States, smoking rates have gone down quite considerably since their peak in the 60s and 70s. And even since this slide was, I'm based in Minnesota. Minnesota's rate is now 14%. But nationwide, we're somewhere between 18, 19%, but about 1 in 5. And I've been working with healthcare professionals that are serving these clients in this population and oftentimes ask them what percent of the population do you think smoke? And many times their estimation is well over 50%. because that's the world that they live in and that they're serving. So let's take a look at those numbers. This is cigarette use among adults with mental health. And the red are higher than 45%. That checkered green is between 40 and 44. And as you go down the color spectrum there, it gets less. But the least amount in this gradation of scale is less than 30%, with a reminder again that the general population is under 20% right now. So indeed, in tobacco control, we really need to start taking a better look at who is left in our population, who's been left behind by the strategies that we've used. And I think we can see that in this next slide. This shows the decrease in smoking among adults since 1997 to 2011. I think the lower graph shows you that progression downward with the general population, those without serious psychological distress. But the upper bar, in the same environment, those environments that we've worked on to raise the price, to have smoke-free air, to have comprehensive programs, to do counter-marketing, their numbers have not changed. And so when you say when the water rises, all the boats rise, in this case, that has not happened. And it's really something that in tobacco control, we've just really started addressing and looking at. And of course, with our colleagues that are treating people with mental illness and substance use, this is a brand new topic in most cases. So, who's buying cigarettes? 3 in 10 cigarettes, or about 30% of all cigarettes sold in the U.S., are consumed by adults with mental illness. So our populations, again, that can least afford the cost of cigarettes, and sometimes these are the arguments we get when we start talking about a tax increase. The real injustice of this is the targeting of the tobacco industry and the disease and death that has resulted by this disproportionate numbers of vulnerable people that are continuing to use tobacco. And another way to put it is that 3/4 of people who are currently smoking have had a past problem with mental illness or addiction. So again, I think it really helps us to start thinking about how are we addressing these, how are our materials, how are our trainings, how are our policy work and our funding addressing this very important population that is still using tobacco at a very high rate. So some of the data that we've gathered in Minnesota, I just want to share. I know that this is a national conference, a national webinar, but I think we're more alike than we are different. So we gathered this information for a summit that we held in Minnesota, and it's percent of adults who are current smokers by their mental health status. And again, you see, if people have ever had depression, it's almost double. Those who have serious psychological distress, again, very high numbers. And then if they're receiving treatment or not. It just, as we dig deeper into this topic and get that data and that information we need, I think that it's really important to take these things into consideration. And this is one that I heard a few years back when I first was really introduced to this topic by Dr. Joe Williams from Rutgers University, that people with serious mental illness die on an average 25 years earlier than the general population. We're talking about loss of life from tobacco in the 50s, and that's just not acceptable. It is just not acceptable. So I know this is a very detailed slide, but it's you'll get to share them, and if you really like detailed data numbers, I would push you to the left and just see the highlighted numbers that the percent of deaths due to tobacco were 2.7 times higher in Minnesota. This is Minnesota data of people with serious mental illness than those without. And then when you layer on those with serious mental illness and using tobacco, you'll see that in the last paragraph, those with serious mental illness and tobacco-related diagnosis, those same diagnoses that the general population has, heart disease, stroke, COPD, lung cancer, are 32 years earlier than adults without serious mental illness and using tobacco. So again, a very, very important population and unbelievable impact on their life expectancies. So some of the things we have to deal with as we talk about this and as we talk about them in their housing situations, that there is an indifference about this population, that tobacco use is a low priority. They don't see a relationship with treatment. They're unaware of the data, and that's part of our responsibility in educating that the impact is great and the data is there. Some folks also say that their clients don't want to quit smoking. The data shows just the opposite, that they want to quit. They're not sure they can do it, but they have the desire to quit at the same rate as the general population. And then resistance, that resistance in overall, both the providers and those clients, to embrace and encourage. I mean, sometimes we actually use tobacco in these settings as a reward and to control behavior. I was noting to my colleagues on the line that I just checked Betty Ford's website, what to bring to treatment, and nicotine products are very clearly spelled out as something to bring to treatment. And then I want to say that these are people with faces and with real lives. This is my sister Susan. She was born developmentally disabled. She lived her whole life in public housing. She lived in residential treatments, residential centers. She didn't have treatment. She was placed in public housing. I had to place her in adult foster care. She ended up in a group home, and I would just say that she never, in any of those situations till the very end of her life, was the environment that she lived in smoke-free. The public housing had smoking. The foster home did not, but it was very much a challenge to get that. So for me, this is personal. For me, this is a very special population, a population that has really taught me a lot about life's lessons. And I thank you for the time to share why this need is so important. So I'm going to hand this back to Carrie.
Well, what I'm going to do today is to talk briefly about findings from a research grant we received in 2014 from Clearway, Minnesota, to explore barriers to reducing tobacco use and secondhand smoke exposure in assisted living residents, and to identify strategies for ensuring a tobacco-free environment in these settings. We originally proposed to examine this issue in settings known in Minnesota as adult foster care. But as we learned once we began our research, only a handful of states use this term. In Minnesota, this setting refers to a licensed living arrangement that provides mentally or physically impaired or ailing adults around-the-clock support, including food, lodging, supervision, and household services, both in corporate adult foster care facilities and in private residence. Probably one of the most challenging issues we dealt with in our research was sorting through the different terms, services, and definitions of these settings. Although all states have some similar type of arrangement for impaired adults, not all of them use adult foster care to describe these arrangements. States vary in the terms they use for assisted living settings, the populations these residents serve, assistance they provide, and ways they are regulated, certified, or licensed. Here are just a few of the more than 30 different terms used around the country. Because of each state's inconsistent nomenclature and disparate services and regulatory features, we ended up using the term assisted living in our study to refer in general to residential settings, including adult foster care, where impaired, elderly, or ailing adults receive 24-hour support, including food, lodging, supervision, and household services. The common denominator is that functionally impaired adults reside in a home or facility. They receive assistance with basic daily tasks, and the home or facility itself is prohibited from providing skilled nursing care. Unlike nursing homes, they don't require a nurse to be on site 24/7. Also, while nursing homes receive federal funding and are regulated and overseen by the federal government, assisted living residents are regulated by the state. We convened a national advisory panel of experts in tobacco control, elder and housing care, assisted living, adult foster care, and adult tobacco addiction and cessation, as well as tobacco use among persons suffering from mental illness or other cognitive impairments. We then conducted legal and policy research and analysis and a 50-state survey of all state laws, rules, and policies regulating tobacco use in assisted living residents. We also conducted a dozen open-ended key informant interviews with experts in assisted living and adult foster care from 6 states where smoke-free adult foster care policies were required by state law, as in Michigan, or by some local governments or providers, as in Alaska, Minnesota, Montana, New Jersey, and Oregon. Our purpose was to identify obstacles and challenges regarding the adoption, implementation, and enforcement of smoke-free measures in adult foster care settings, to learn of tobacco cessation services or information provided to adult foster care residents and providers, as well as lessons learned. Our key informants were all highly experienced in working with vulnerable adults, especially those with behavioral health disorders and intellectual or physical disabilities. They included social service administrators, attorneys, licensors, managers. Most had more than 10 years of experience in adult foster care, and one individual, a state manager, had played a key role in the regulation, inspection, and investigation of adult foster care homes for 40 years. The range of experiences gave us the opportunity to hear a variety of perspectives on this topic, including views of those who had personal as well as professional experiences with assisted living. One of our goals was to look at the national landscape of adult foster care, assisted living settings, and smoke or tobacco-free policies in these residences. We also reviewed each state's Clean Indoor Air Act and smoke-free law to see if these settings were covered. Very few states included these residential settings in their smoke-free laws. Once we compiled this data, we summarized it in 2 publications and posted it on our website. We developed an online 50-state map where users click a state and go to a summary of each state's tobacco-related laws or policies for assisted living or adult foster care residents, each of which is hyperlinked. Most state smoke-free or Clean Indoor Air Acts exempt these public or private residents from workplace or public place smoke-free requirements. Also, most state licensing requirements for assisted living or residential care settings do not include smoke-free policies. Instead, many providers adopt their own smoke-free or tobacco-free requirements, which they enforce with varying degrees of success. As part of our grant, we also developed a toolkit of helpful resources and publications on addressing tobacco use in assisted living settings that we're posting on the Public Health Law Center's website. Okay, so in brief, our interviews with providers confirmed the prevalence of several common myths about tobacco cessation and behavioral health, including the idea that people with mental illness or other cognitive disabilities are less motivated or able to quit than others. In fact, recent studies by scientists, mental health professionals, and champions in the field, such as Dr. Jill Williams, have debunked each of these statements. Indeed, smoking can actually complicate the treatment of patients with mental illness. Data actually suggests that smoking cessation can help reduce mood, anxiety disorders, and depression. Research has found a clear association between smoking cessation and positive behavioral health outcomes. So why adopt a tobacco-free policy in assisted living residents? Well, in addition to all the obvious health risks of tobacco use and secondhand smoke, many of the residents in these settings have compromised health, take prescription drugs, and are otherwise vulnerable. They're especially susceptible to the effects of tobacco and secondhand smoke. A related concern in assisted living residents, and indeed any setting where cognitively impaired or disabled adults smoke, such as nursing homes and long-term care facilities, is the risk of fire. This is both a public health and a safety issue. Several administrators and social service workers that we interviewed mentioned horrific incidents of fire caused by smoking by residents in adult foster care or other assisted living environments, some of whom were on oxygen. In one state, residents turned off the smoke detectors in their bedrooms so they could smoke. When providers became aware of this, they installed detectors that could not be easily disabled. As Pat's mentioned, in addition to the public health issue, there are social justice concerns. She's already discussed this, so I'll move on. Smoke-free workplaces and multi-unit apartments and affordable housing are becoming the norm across the country. For those individuals who are already suffering from issues of low self-esteem, struggling with mental illness, substance use, or other issues related to low SES status, tobacco use may further stigmatize them. So what were the obstacles? We knew that a high number of staff in assisted living residents smoke, but we were startled that tobacco use was so prevalent among attendants, personal caregivers, and administrators, even in settings where a smoke-free policy was in place. We repeatedly heard reports that up to a third of the staff smoke. Staff would take smoke breaks with residents, would buy tobacco products for them or drive them to purchase tobacco products, and if they resided in the same facility, would smoke in their rooms when they were off duty. For example, we talked to a group of adult foster care providers and administrators in Alaska, and they told me that going smoke-free for staff would be far more of a challenge than going smoke-free for the residents. If the staff were on extended shifts and couldn't leave the premises to smoke, they'd go outside regularly and smoke, and they'd return reeking of tobacco smoke, which would frustrate those residents who wanted to smoke and weren't able to leave the premises. The issue was compliance by all and equitable enforcement. Also, the use of smoking as a way to deal with stress, anxiety, medication side effects, and boredom was pretty common for residents and staff as well. Assisted living providers are chronically short of funding and qualified staff and may resist policies that make it difficult to monitor residents who smoke, to escort them outside for smoke breaks, and to ensure that resident elopements, that are unauthorized departures, don't occur when staff is preoccupied. Also, residents with mental illness or other disabilities often face special challenges in quitting smoking and may need counseling as well as access to a combination of nicotine reduction therapies. Related concerns for assisted living providers is that enabling residents who are old, frail, and may be in wheelchairs or on oxygen to take regular breaks outside to smoke might increase the likelihood of accidents for which the provider would be legally liable. Although e-cigarettes and other electronic delivery devices were rarely mentioned as a problem in our interviews, a few informants said they expected that these products would become more of an issue down the road. Similar concerns were expressed about the rights of staff to regulate the smoking of marijuana on the premises. Some facilities already permit medicinal marijuana in ingestible forms. As more and more states move toward the legalization of marijuana, use restrictions in settings like assisted living residents, nursing homes, and long-term care facilities need to be considered. So here are a few of our policy recommendations for state and community leaders who are considering addressing tobacco use in assisted living residents. One option is to promote state smoke-free laws that do not exempt assisted living or residential care homes or facilities, but are as comprehensive as possible. Another option might be to include smoke-free residences as a licensing requirement in state regs. Also, it's clearly important for mental health, substance use, and primary care providers to integrate tobacco cessation services with their services. State and community leaders should also encourage social service workers and professionals from related fields to work with tobacco control professionals and do what they can to support comprehensive insurance coverage for tobacco cessation treatment. And here are a few of our policy recommendations for assisted living providers interested in addressing tobacco use in their residences. Careful planning, assessment, and communication are all key. It's critical to disclose and discuss the policy and resident pre-admission screening, house rules and regulations, employee interviews, and staff policy manuals. Make sure the policy is clear and easy to understand and that all terms are carefully defined. Penalties for violating the facility's tobacco policy should be enforced fairly, consistently, and be sufficiently severe to discourage attempts at circumvention by other residents, including staff or visitors. Facilities should make every effort to prevent the use and trafficking of tobacco contraband by visitors. And if at all possible, assisted living providers should make tobacco dependence information and resources available, along with quitline information and access to NRT products. Finally, although states differ in the way they set up and regulate assisted living residents, some of these settings are unaffordable or public housing. As you know, last fall, the Department of Housing and Urban Development proposed a rule requiring that more than 3,100 public housing agencies across the U.S. prohibit lit tobacco products in all living units, indoor common areas, administrative offices, and all outdoor areas within 25 feet of housing and administrative office buildings. The rule is likely to take effect in the next year. Since some residents in assisted living reside in public housing, this rule will affect many of the populations we're describing today. So we might want to think about the best way to work with our local and national partners and housing authorities to help make this transition to smoke-free living as smooth as possible for them. Here's the Public Health Law website where many of the resources and publications we've discussed today are available. And here's a sample of one of the web pages where our assisted living resources are housed. We'll be adding additional items to these web pages over the next few weeks. Thank you. And our next speaker is Jessica, who will look at smoking policies in another setting with vulnerable adults, nursing homes.
Thank you, Carrie. In addition to the host of cancers and chronic diseases caused by smoking, evidence also suggests smoking and exposure to secondhand smoke in older adults is associated with cognitive decline and dementia. Smoking interferes with various drug therapies taken for chronic conditions common to the elderly, and many older adults have physical difficulties or cognitive deficits that make the nursing home resident 2 to 3 times more likely to be severely burned in a fire than his or her community-based counterpart. While smoking prevalence among those aged 65 and older is lower than that of younger age groups, at just 8.5% in the United States in 2014, the smoking prevalence among this population has changed very little over the past 15 years. Since 1999, smoking prevalence has decreased just 2 percentage points, from 10.6% to 8.5% in 2014. Comparatively, you can see that smoking prevalence has decreased at a greater rate among all other age groups for adults in the U.S. 18 to 64 years old. Despite the known health consequences of tobacco use, nursing home settings have thus far attempted to strike a balance between caring for residents' health and respecting residents' self-determination. Whether or not nursing homes allow resident smoking has been determined on a facility-by-facility basis. Few studies in the United States have examined smoking policies in residential facilities for older adults. Tobacco use policies have a direct effect on the smoking habits and health of older adults, as well as a direct effect on the health of non-smoking older adults and employees as a result of secondhand smoke exposure. For the next several minutes, I will be discussing a project that examines tobacco policies in nursing home facilities throughout the United States. Resident smoking in nursing home facilities poses a difficult challenge for administrators, healthcare workers, residents, and their families. Well-written and well-communicated tobacco use policies have the potential to influence behaviors of residents and staff, provide protection for non-smokers, and they communicate a precedent of safety while protecting the facility from related legal liabilities. So in this project, the actual tobacco policies of nursing home facilities provided the data of interest. A 2-stage recruitment process was conducted, where first a list of physicians was obtained from the American Medical Directors Association. This list was then grouped into the 4 geographic regions used by the United States Census Bureau. Physicians were then randomly selected for inclusion in the study within each of the 4 geographic regions. Recruited physicians provided contact information for an administrative contact person who then mailed a copy of the facility's policies addressing tobacco use. This may have been the standalone policy or a subsection of other policies, such as those addressing local fire ordinances, state laws, and so forth. Because there are no published standards for examining resident smoking policies, the Center for Social Gerontology and the Joint Commission on Accreditation of Healthcare Organizations criteria were used to broadly define what policies should include. The Joint Commission's scores of excellence require a policy to discourage the use of smoking materials, provide appropriate precautions to prevent fires and protect non-smoking patients from exposure to smoke, and they encourage smoking cessation activities be provided. Based on the Center for Social Gerontology and the Joint Commission, a thorough smoking policy should address each of 6 categories shown here. Rubrics were developed to systematically describe and rate the comprehensiveness of each nursing home's tobacco policy. Each rubric category contains specific criteria. These criteria varied to reflect the smoking regulations for the type of facility. We categorized facilities into those that allowed residents to smoke indoors and outdoors, those that allowed residents to smoke outdoors only, and facilities that were non-smoking. 2 separate policy reviewers assigned a score to each criterion, with discrepancies being reconciled by the project PI. 53 nursing homes returned information, and 6 of those reported that they did not have a written policy or were transitioning from a smoking to a non-smoking facility, leaving us with 47 nursing home tobacco policies reviewed in our final sample. Facilities ranged in size from 35 to over 700 beds and were evenly divided among for-profit and non-profit. They were located in 32 states that were geographically representative of the density of nursing homes in the United States at the time of survey. Almost all of the facilities allowed resident smoking to some extent, 48% outdoors only, and 40% allowed residents to smoke indoors or outdoors. Across all facilities, policies generally lacked overall comprehensiveness. Tobacco education or cessation assistance was not addressed in 85% of policies. Inclusion of statements addressing education and cessation can inform residents of services available should they choose to access them. 1/3 of policies thoroughly addressed smoking areas. A policy that designates where smoking is and is not permitted leaves little room for misunderstanding. Clarity and comprehensiveness on this issue could empower staff to enforce smoking regulations that may otherwise be an area of contention between smoking and non-smoking residents. Further, only 8% of facilities comprehensively addressed policy notification and what occurs if the policy is violated. Among facilities that allowed smoking, almost 80% failed to include statements referring to employees' rights to choose to assist residents with their smoking, and none included assurance of non-retaliation should staff choose not to assist, which gives employee choice more credence. Half of policies failed to address smoking eligibility criteria. A policy that is sensitive to variance in a population allows for an array of outcomes, while at the same time provides a standard from which the facility can practice. Over half of policies did not address the availability and use of safety accessories, such as fire protective aprons, and 88% failed to mention precautionary measures for smoking residents who use oxygen. This project is not without limitations. There were a small number of non-smoking facilities represented, although this may be indicative of the small proportion of non-smoking facilities nationwide at the time of data collection. There is the possibility of sampling bias. Our facilities were recruited from the American Medical Directors Association list, and so those without representation on this list were excluded from our sampling procedures. Also, those without a policy or those who deemed theirs inadequate may have been less likely to participate. Finally, data may now be dated and no longer representative of the current landscape of nursing homes tobacco policies in the United States. There is no national mandate regarding whether or not nursing home facilities should continue to allow residents to smoke. State mandates, as Carrie pointed out, may exist. For example, in 2013, the New York State Legislature passed a new smoking ban on healthcare facility grounds. The law prohibits smoking on or near the grounds of hospitals and nursing homes, except for designated areas on the grounds of a nursing home. While nursing homes may have practices that are more extensive than their policies portray, creating policies that guide practice can assist these facilities in promoting environments that align with their goals and desired practices of protecting residents and staff. As policy development occurs, nursing homes may wish to draw on the experiences of other multi-unit dwelling establishments. Many public and private multi-unit housing apartments, which face the similar dilemmas of respecting residents' self-determination regarding tobacco use, are in fact opting to maintain smoke-free facilities. Our next presenter will be Jen, discussing policies in Ontario, Canada.
Thank you, Jess. So today I will be discussing our preliminary review of legislation governing tobacco use in Ontario, Canada retirement homes. So in Canada, 8% of the senior population live in communal residencies. This includes nursing homes, retirement homes, and long-term care homes in Canada. As the baby boomer generation continues to age, the demand for these facilities continue to rise. In collective dwellings in Canada, the population has almost doubled in the last 15 years. And as you can see here, the percent of smokers in the general population as compared to those 5 or older, while smoking prevalence 15 plus trends downward at a steeper rate, while smoking among those 55 plus has remained relatively over the time period shown. This is similar to the graph that Jessica shared in her presentation. Smoking contributes to 8 of the top 14 causes of death years and interferes with various drug therapies. Even seniors who don't quit until the age of 60 see an increase of 3 years on average in life expectancy. Health risks decrease after seniors quit, and the deaths from smoking-related morbidities decrease after seniors quit, and quality of life improves. There's documentation that smokers in Ontario, Canada, particularly senior smokers, engage in high-risk cigarette use, such as cigarettes unattended or smoking in bed. Several alleged tobacco-related fires have occurred in Canada in recent years. Age-related changes in vision, power and coordination may contribute to residents' decreased morbidity. In 2000, residents in Orillia, Ontario passed away with an alleged tobacco-related fire. In 2032, residents in Île-Verte, Quebec, passed away. And in 2016, most recently in Toronto, Ontario, 3 residents passed away. So with growing recognition, legislation may influence tobacco use, surveillance of local level laws, especially as they pertain to smoke, have been identified as a top priority for tobacco control. In understanding the implications of these deaths in facilities across the country, the purpose of our study that I'll be describing in more detail is to provide a descriptive analysis of legislative policies, the regulatory purview of tobacco use in retirement homes. The study examines the statutory framework of municipal or regional tobacco use legislation to develop a comprehensive understanding of the regulatory context of retirement homes in Ontario. Although retirement homes may indeed engage in practices that are more comprehensive than the regulations portray, examining the potential influence of tobacco legislation is a first step in safeguarding the needs of smokers and non-smokers alike. So some background into Canadian legislation, as it is a little different from U.S. regulation. On the left-hand side is federal Canadian legislation. The Tobacco Act actually governs the manufacture, sale, labeling, and promotion of tobacco tobacco products, and the Non-Smokers Health Act really only restricts smoking in federally regulated workplaces or public places under federal jurisdiction. So ultimately, most regulation at the provincial level happens either by the provincial government or by municipalities. In Ontario, the Smoke-Free Ontario Act prohibits smoking or holding lit tobacco in enclosed workplaces and enclosed public places in Ontario to protect employees and the public from the hazards of secondhand smoke. In addition, the provincial framework restricts smoking in common areas in condominiums, apartment buildings, elevators, parking garages, and other multi-use rooms, and also restricts outdoor smoking in select environments such as hospitals and healthcare facilities. Despite indoor and outdoor smoking restrictions placed on communal residencies and healthcare facilities, retirement residencies, because they are privately owned in the province, are exempt from the Smoke-Free Ontario Act. Ontario municipalities have the authority under the Municipal Act of 2001 to enact additional bylaws containing provisions that are more restricted than those found in the Smoke-Free Ontario Act. In fact, many municipalities in Ontario have passed additional legislation with provisions that exceed the requirements for the Smoke-Free Ontario Act. So research examining the prevalence of smoking and tobacco use policies in long-term care or nursing home facilities is limited, and the purpose of our study is to provide that descriptive analysis of legislative policies. Despite all of the regulations, both federally and provincially, as I mentioned, retirement facilities are exempt. And so before I continue, I want to first define what is a retirement home and what is a long-term care home, because these are terms that are used in Ontario and may not be used in your state. So for the purpose of our study, a long-term care home is defined through Ontario's provincial legislation that really encompasses nursing homes, long-term care homes, homes for the aged, and rest homes. Long-term care homes are actually regulated by the Smoke-Free Ontario Act and prohibit resident smoking. Retirement homes, on the other hand, are the privately owned and operated residential complexes that are occupied primarily by persons aged 65 and older and provide at least 2 care services, such as nursing staff or food service, available directly or indirectly to residents. This study exclusively examined retirement facilities because of provincial funding directed towards long-term care homes and nursing homes, they were covered by provincial regulation. So retirement homes, while smoking is prohibited in common areas, there were no additional regulations that safeguard smokers and non-smokers from the risks of smoking elsewhere in the facility. So if I wanted to smoke inside my room, that would be absolutely okay, that there would be no additional regulation through the Ontario Act. So in terms of methodology, retirement homes were grouped in 14 categories called the Local Health Integration Network. The Local Health Integration Network is a categorization used by Ontario's Ministry of Long-Term Care, Health and Long-Term Care, and they are essentially health for regional administration of public health care services in the province. And they really plan, integrate funding for all public health care services at a regional level. So we essentially categorized 686 retirement homes in Ontario, Canada, within this distribution. And we did a stratified random selection of these homes to ensure that we had sampled from each of the 14. And the original list of 686 retirement homes through the province's Retirement Home Regulatory Authority. So a random selection produced a sample of 75 different retirement homes, 19 of which of additional municipal legislation. The remaining 48 homes are in regions of the province that defer to the provisions of the Smoke-Free Ontario Act, which prohibits smoking in common areas but does not regulate smoking within private rooms of residence. The bylaws governing these 19 facilities in areas governed by municipal legislation supplied the data for this project. So our rubric was developed based on the previous study by Watt that Jessica was just talking about and examined similar categories. Administrative and authority issues, which really looked at if the bylaw was present, what they described underneath their tobacco categories, if the legislation, identified employer responsibilities. It looked at notification of the bylaw, issues relevant to resident smoking and non-smoking, whether that be there's identified smoking areas, smoking signage, receptacles. We looked at concerns, so whether that be the use of safety accessories, was there any notification of the bylaw for residents and staff, and then was cessation assistance provided. And in our preliminary results, administrative and authority issues were most commonly addressed by the bylaws, and less than 15% discussed signage for smoking and non-smoking areas. None of the bylaws actually addressed safety concerns or cessation assistance for the population. So what does this mean? Further research continues to be necessary to impact of the regulatory framework in retirement homes in Canada. Obviously, our study only looked at one province across the country, and of course, the regulatory framework changes as we move from one province to the next. In Ontario, replication of this and other methodologies in other provinces in Canada would provide lawmakers with a more comprehensive regulatory framework governing retirement homes. In terms of limitations, the sample size, it only looked at, through our random selection, it only looked at a small portion. We're currently in the reviewing additional bylaws for a more representative sample. In terms of changes to the retirement homes regulatory authority, when we began our research into this study, the RHRA was relatively new. In 2010, the province essentially retirement home regulatory authority with new legislation, understanding that and needed to follow specific guidelines to ensure all of the homes were compliant with regulation. And so our initial sample has 686 retirement homes. At this point has probably grown the size, and then as we know, more homes are being created for these facilities continue to rise. We also excluded any pending municipal bylaws in our initial scan. Any that was looking or discussing this in committees or in minutes were not no final product for us to review. And overall, while communities may have progressive legislation that is intended to protect smokers alike, the exemptions of retirement homes in these bylaws continues to marginalize the aging population. In Ontario, really, essentially, there needs to be replication of this and other methodologies in provinces in Canada to really give lawmakers a more comprehensive picture of the regulatory framework governing retirement homes. In addition, our paper really recommends that there is a need to re-examine the Smoke-Free Ontario Act in Ontario specifically to ensure that retirement facilities and retirement homes are included and no longer exempt from this overarching legislation. And with that, I am going to turn it back over to Carrie. Thank you.
Thank you, Jen, and thank you, Pat and Jessica, as well, for your fantastic presentations. I apologize for a few of the audio glitches at the end here. A few questions have come in, and while we're consolidating them, I just want to mention again that an archived recording of this presentation and slides will be available on our website in the next few days. Okay, so we did get a question, and I can field this one because it's sort of law and policy related regarding HUD. It's, is there a time frame for when HUD will finalize smoke-free policies for public housing? And as you know, HUD is continuing to review all its comments. It's going through a prolonged executive agency clearance, after which it will post the final rule. And then it needs to allow public housing authorities up to 18 months to implement smoke-free policies. So the rule is likely not to take effect until 2017. And the follow-up question here was whether or not this HUD rule would also apply for those that accept Section 8 vouchers, and it will not. Now, we have a few questions for, I guess, both Jessica and Jen. Are e-cigarettes used much in nursing homes or the Canadian long-term care facilities? And the next question here was, what about smoking or vaping marijuana? So I'll let either of you field out those questions.
Sure, thanks, Carrie. I will comment on the United States first. Simply, when we conducted our survey, electronic nicotine delivery devices were not on the market at that time, so they were not included in what our description of an ideal policy should include. And similarly, neither was medical marijuana. But I do think that monitoring and surveillance of e-cigarette use and marijuana use among the aging population specifically will really help facilities and lawmakers have some guidance on the potential need to include these products in policies and in legislation. So Jen, I don't know about Canada.
Well, in terms of our research, there were actually one or two very progressive bylaws that we examined that actually did address e-cigarettes. None of the bylaws that we came across mentioned or referenced medical marijuana. As in the United States, there's a growing conversation in Canada over medical marijuana regulation. But for us, you know, one of the impacts of this study is as we continue to see the rise of e-cigarettes, what does that mean for regulation in Canada? And it definitely is something that needs to be addressed.
Okay. Thank you very much, both of you. Pat, this is a question I'm going to throw out to you. Do you have any ideas on ways to facilitate dialogue among non-traditional partners in public health, behavioral health, tobacco cessation, insurance, or social service administrators?
It depends if you're talking one-on-one or in a group, but I think it's one of those situations where you have to, quote, meet them where they're at, but we're headed down a path that, in all honesty, my experience, and we've trained literally thousands of social workers and providers and they are very unaware of the data. They are stunned at it for the most part, and then they really start questioning their own systems and their beliefs and how it's manifested in their practices. And I would just say, you know, listen and, you know, offer guidance, support, suggestions, and small steps at a time. I've had a facility say, well, we're not going to possibly do a grounds policy, but when we talked about what was doable, it was doable to not have smoking at that designated bench on a Thursday and start practicing it. So I would say think about where tobacco control community was probably 20 years ago.
Oh, okay. Thank you. We have a comment. Your thoughts on designated smoking areas. And I'll just throw out that in assisted living residences, they do include, often these policies do permit smoking in designated enclosed and ventilated areas, such as common areas or smoking rooms. And most do permit smoking outside on the grounds. But if anybody has any other thoughts on designated smoking areas, please chime in. Okay. All right. All right. Well, you know, I think I've got one more question. It's kind of interesting. It has to do with many of these settings have elderly residents. Are there studies that show any links between age-related dementia and smoking?
There are, and this is Pat from the Lung Association. There are, one of my staff just did a fact sheet with some references that we're not quite done with yet, but once we have it finalized, I'll definitely share with Carrie, and she can share with the group.
Yeah, thank you. And obviously from just a public safety perspective, it's obviously dangerous for cognitively impaired residents to smoke when they may forget to put out the cigarettes or maybe smoking around oxygen tanks. So it's just a risky situation all around. Well, thank you all very much. Thank you presenters, Pat, Jessica, and Jen, and thank you all for attending our webinar. Have a great day.